So, by the way, that's what we found when we started in 1992. We said, let everybody make a decision together and we learn together. And that's the best way to do it. Can we have the next panel members? And Ray, where are you? So while we're miking up, I'll introduce myself, Claudia Henschke, and you can say your last name.
Yes, I know. I can't say it, but I'll try. Ray Osarogiagbon. I'm a thoracic medical oncologist at Memphis, Tennessee, chief scientist for my healthcare system.
Yeah, and we're very pleased to have you here. So
thank you, Claudia. Much obliged, honored to be here with you. Looks like you have a pretty interesting group here.
Hi, everyone. My name is Mikhael. I'm from Egypt. I'm a radiologist and a professor of radiology at National Cancer Institute. First of all, I would like to thank Claudia and David. They were in Egypt lately, and we discussed together the lung cancer screening, which we started 1 year ago. Now our anniversary for the first year of lung cancer screening will come next June, next month. We're very excited. It's a very short-term program, but again, we have 27 governorate in Egypt. We started the first phase for 6 months by 9 governorate, the second phase 6 months, other 9 governorates, so total of 18 governorate with total of 45,000 low-dose CT scan done. The numbers are exciting, but again, the challenges are big. Egypt is a big country. We have over 100 million people population. So I believe starting where the others ended would give us a great chance. So we started with implementing a unified system, a centralized location for reporting, training the radiologist for detecting lung nodules, and now we're using the AI. We're collaborating with Mevis and as well as Coreline. Both of them are incorporating the systems in our
so
reporting.
Maybe we should let the other panelists introduce themselves, and then we will get
okay, great. Thank you.
Okay. Good afternoon to you all. So I am Jane Afriyie-Mensah from Ghana in West Africa. I'm a pulmonologist, and where I work in one of the teaching hospitals. I am, what else? I'm the vice president of the Ghana Thoracic Society. I would just say that we are putting our house together with regards to lung cancer screening, and I'm sure we'll talk more about the country dynamics. Thank you.
Thank you very much. And I'm Lawrence Atundo Murunga. I work with the Multinational Lung Cancer Control Program based at the Moi Teaching and Referral Hospital in Eldoret. That's the second largest public hospital. Dr. Claudia, we have been very persistent. We have been persevering. And we're very glad that we are going to now have the team that will finally constitute the best way to go with screening. So we look forward with a lot of optimism. And we are hoping that maybe that's to honor the statement. We really appreciate it for this particular Congress. It is really come at the right time for us. Thank you.
Good evening, everyone. My name is Chinedu Anosike. I'm representing Nigeria. I like to tell people that I have 2 lives. So in one life, I work in the NHS, and in the other life, I work in Nigeria, so 60-40%. The kind of work I do in Nigeria is teleradiology work. I formed a teleradiology group with a couple of African radiologists in diaspora in 2019. Started out as a small project, and then COVID happened and it exploded. And the demand was great because with a population of 220 million, you have about 500 radiologists in Nigeria. So we're grossly underserved, and I tend to look at radiology as a global commodity, and there is demand everywhere in the world for radiologists. Nobody has enough. So we are adding to the capacity of radiologists in our environment. And the idea about lung cancer screening is one that really appeals to me because you can make quick wins that way. The cost of treating somebody with a stage 4 lung cancer is exorbitant. And if you have a stage 1 lung cancer, the difference is pretty clear, like we've heard today. So I'm keen to continue this conversation.
Good evening. I'm Wendo. I've already introduced myself earlier. I'm from Matthias Wendo Ethiopia Cancer Society. I'm not a physician, but human resources manager by profession. I joined the war on cancer after I lost my son due to leukemia. He was about to leave for National Cancer Institute for bone marrow transplant. He couldn't make it. That's why we changed the tragedy into opportunity, and we formed our society. Today, our society is a national local NGO with 30 staffs and implementing 9 projects, 3 on tobacco, 3 on lung cancer, 1 on pain plus, 1 on unhealthy diet and the childhood cancer. Our society is turned into one of the most respected and trusted NGO in Ethiopia. Please come and work with us to make a difference. Thank you.
Great. Thank you all for introducing yourself. So we'll just get into the heart of it. Question, do we really know the extent of lung cancer in your various countries? What is the current perception of lung cancer as a public health problem? Anyone can start.
Okay.
Yeah.
So, well, what I would say is that back in Ghana, the story had maybe a few years back had been, do you truly have lung cancer? For most people, it was more like non-existent or very, very rare. And I would say that TB, from where I come from, is a very strong confounder and causing a lot of problems for us. But in 2012, there was a survey that said that lung cancer, from the cancer registry, actually, which is also very under serviced in terms of data information or input. So it did say that it was the 10th cause of mortality, cancer mortality, 5.3% in terms of prevalence for men, for women, insignificant. That was 2012. So from that time, no study per se or no survey. And then in 2023, we just decided to look at the respiratory clinic in just that center. And over a 3-year period, we had 90 confirmed cases. For us, a lot of patients we don't get to confirm because of diagnostic gaps for one reason or the other. And we had 90 cases. So we felt that, no, the story seems to be changing. And this is where we are. We know we have the diagnostic gap, but we're working towards it. We've noticed this, and even amongst just this 90 cases, 1 center. So we are wondering what's going on around and what is, because almost everybody with an abnormal chest X-ray somehow gets a diagnosis of smear negative TB. And just this 2024, again, 1 center, we are looking at about 30 cases confirmed. We are not talking about the ones that we are suspecting that we haven't confirmed yet. And the data is pretty similar to what is being shared around. More female, non-small cell, more female, about 2/3 female, almost all non-smoking. 90% of our documented cases are non-smoking. We would say that because it's just been 1 center, we are working hard to collaborate with the other teaching hospitals and get the other doctors on board. There are just 2 pulmonologists at the moment, but we are working with other specialists to try and get patients across.
So what's the experience in the rest of the continent? Lung cancer underestimated or not a problem?
I would say grossly underestimated. I think it's just a tip of the iceberg. Most of the data out there is from GlobalCam, WHO. It's very low numbers given for Nigeria. And from my experience working in that space since 2019, there are a lot of patients who present late, stage 4 disease. And most of them, a lot of them are young because we have a very young population. 70% of our population is under the age of 40. So that's very young. And we're talking about a population of 220 million people. So a lot of these people present young and they present with stage 4 disease, and a lot of them are non-smokers. There's a lot of things driving this thing in the environment. There's not enough research to indicate what these drivers are. And in terms of picking up early. My colleague from Ghana has just mentioned tuberculosis. That's a big confounder. A lot of the changes on TB, X-rays or CT scans can mimic lung cancer. So a lot of the pulmonologists in that environment would start off with treating people for TB when they're symptomatic. I know what we're talking about is not the symptomatic cases. We're talking about screening. What we have is definitely an underestimation because we don't have a robust cancer database at present.
What's the Kenyan experience?
Thank you very much. I felt like he was speaking my mind, but this is really good because we share a lot of experience. In Kenya, lung cancer is largely underestimated. Basically because there's pretty not a robust way of reporting. We're looking at cancer registry, and when you look at cancer registry, there are many gaps that we find, both population-based and hospital-based. In the entire country, we basically almost have just 2 active centers that have both population-based and hospital-based cancer registry. And also because most of these cases are never reported, and more so because the cases come late. Okay, the cases don't really come late. They're with us, but we diagnose them very late. So when someone dies of a condition, let's say, for example, tuberculosis, they assume to die for tuberculosis, and yet they have died for lung cancer. These cases are never picked up by the cancer registry. And this is why when you look at the GlobalCan, as he said, most of this data is being reported by GlobalCan. In 2020, the data showed that out of 700, lung cancer was actually position number 14 for all the instances happening in the country. And yet the incidence reported was 794 vis-a-vis 729 deaths. This gave a very high mortality of almost 92% of mortality for lung cancer. So that is an area that we really need to really talk about.
So is the experience in Ethiopia and Egypt any different than what you've heard?
I would say.
When it takes to Ethiopia, we don't have a national cancer registry. We have only one population-based registry at Addis, at tertiary hospital. And from other reliable sources, lung cancer is 9th in terms of prevalence and 6th in terms of mortality. But from what we have witnessed in our last 4 years with the implementation of MLSCP, it is a multinational lung cancer control plan in Africa in 5 countries. Yeah, it is an elephant in the room, but due to competing priorities, the 9 projects I told you, we are closely working with the Ministry of Health. They do understand that it is growing and it is visible, but because of competing priorities, they are highly reliant on our intervention.
So tobacco or not tobacco related? We heard 3 people say not tobacco related in their countries. How about Ethiopia?
I think the same is true. The same is true, and that is the irony, because we are saying that more than 80% of risk factor for lung cancer used to be tobacco, but this time around it is different, and
And
in Egypt, we don't have accurate number, but according to National Cancer Institute, the last study and last statistics was 2018, lung cancer was the 5th most common among men. Last year, it turned to be the 3rd most common cancer among men. So it's rising. We have a large population that are smokers. We say that the main cause for lung cancer in Egypt is smoking or passive or negative smoking, because usually small spaces closed, and everyone who smokes, negative smoking impact, even female now, are increasing in number, either smoker or negative smokers. So the numbers are increasing. We're waiting for the new GlobalCan, but again, the GlobalCan numbers are not really accurate, but again, these are the numbers that we can rely upon.
So one common theme here is the paucity of data. That seems to be a really big part of the problem. So is it conceivable that African consortiums can come together to overcome this problem, create some common infrastructure for data screening and so on? What do you think?
For me, as the Egyptian, I believe it has to be this way. It has to be a one big unit with the help of the Western countries. That's what I think about, and open the door for the new way of screening for lung cancer and implementing these kind of tools according to what happened over the past 20, 25 years. We can take these results and implement it gradually throughout the region. Basically, each country has its pros and cons. So we can use the resources and use some way of helping tools to create some sort of shared knowledge and shared data that can create a greater outcome. Sure. Yes, statistics, exactly, because we have to find some. No, of course.
Because if you're going to deal with, so you got a double whammy, right? On the one hand, everybody's saying, maybe with a slight exception of Egypt, it's not as heavily tobacco driven as we traditionally think. And then at the same time, you have the major confounder, which is tuberculosis. So what are there unique aspects to your experience? Are there things that you guys are doing already that you could share with us, learn from one another? We could all learn from you.
It's been an eye opener coming in and seeing, meeting some of my colleagues. We've had a few side conversations. The challenges are similar, and some of them they've already kind of surmounted. For instance, in Ethiopia, speaking to my colleague from Ethiopia, I did ask. I mean, in Nigeria, most of the healthcare cost is out of pocket. So trying to get people to pay for a low-dose CT scan that costs somewhere about $200 in that sort of economy is challenging. So the question to him was, how is he able to get people into some sort of screening program in a cost-effective way? Because any screening in our environment has to be cost-effective. So there's a few, nuggets he gave to me, and I told him we needed to kind of continue the conversation, to borrow some things off of him, because it doesn't matter what we say. If we're talking about making this accessible to everybody, we're talking about being truly global. I believe that Black data is underrepresented amongst all the AI talk, radiomics. A lot of that information comes from Black data out in the West, and it's not actually applicable to the wider African continent, because a lot of times that data doesn't look into our environmental complexity. So working together as a group, we will be able to generate this data for ourselves and bring it to some of these AI companies to have us represented in their data sets, because right now I don't think we're represented there.
So what about cardiovascular deaths? I think everybody focuses on infectious diseases. Non-communicable diseases tend to take a back seat on the African continent. As we're talking about lung cancer, maybe we should also talk about cardiovascular diseases and deaths. Is the problem the same there, under estimation, under recognition, or what's going on there?
Sorry, if I get you right, as in how bad is the cardiovascular deaths? Well, in my country, for example, the leading cause of death is from cardiovascular diseases. Of course,
Ghana.
in Ghana. So just as we talk about diagnostic challenges, it runs across. And we see that cardiovascular death is the leading cause.
Really?
Yes. So, well, regarding what we could do or what we could team up to do, I would say that it's very important we share and we come together, because we may learn the epidemiological differences amongst ourselves, and we would be able to rightfully come up with how we're going to screen our patients, because it's a big headache. How are we selecting our patients, especially when smoking is not a big risk? But already by talking, we realize that we are more or less on an even platform.
Same.
We are going to learn from Ethiopia, who started. How are you screening your patients? And I think that will be a good way to go.
So can I just follow up? Because I went to med school in Nigeria all those years ago. But we had this impression, falsely or rightly, that cardiovascular disease, coronary artery disease, for example, is not as big a problem. The cardiac problems we had were mostly related to rheumatic heart disease and stuff like that. Is this a change that has emerged, or is it just that we were living in a relatively data-free world decades ago?
I would say I think it was grossly underestimated, but things have changed
That
as
too.
well.
Heart
Things
disease.
have changed. I mean, there's been a lot of people moving into urban centers. People's earning power has improved. People are eating high calorie diets, sitting on sedentary jobs, working on computers all day. That's also a
So the adoption of a
So
Western
the adoption
lifestyle.
of a Western lifestyle, it means we're having
Yeah, we'll blame
those
the
problems.
West again. You know.
Yeah.
About that.
Yeah.
I think, we conducted situational analysis 10 years ago. And, it is, as I said earlier, the element is in the room. And because of Western way of style, inactivity in Ethiopia, imagine with all these runners, marathon runners and what have you, we are becoming inactive. And we are using unhealthy diet. Obesity is also visible. Tobacco is increasing, and alcohol consumption is also increasing. I'm very mad to learn that Ethiopia beer consumption is we are number one in Africa, and some people say even more than what you have in Nigeria and South Africa. This is Africa is becoming no man's land. We are so much in love with Western way of lifestyle, and we are copying bad behaviors you have just dumped long ago. And this is what I said earlier. Health promotion is the key. Claudia, please, in addition to what we are doing, thanks to the BMSF supported MLSCP I told you earlier, in South Africa, Eswatini, Tanzania, Kenya, Ethiopia, we are making a difference. Even we supported government hospitals to renovate their chest units. And we even procured bronchoscopy and the IBAS. IBAS is the first of its kind in Ethiopia. We are conducting researches, and we are doing all sorts of, because of this generous support from BMSF, but NECD, non-communicable disease, is costing $1 billion USD annually. Ethiopia, 1.8% of its GDP. People are needlessly dying from preventable and treatable disease. We cannot condemn the government because they are full of competing priorities. And it's not fair to ask for more attention for non-communicable disease at the expense of already existing problems. So this is what we are saying. Overseas development assistance is only 1% is going to NCDs. Please tell USAID, PEPFAR, CDC to support us. The government is listening. There is a commitment. One of the friend of mine in NCD commission at the ministry, he said, in Africa, you have so many policies, strategies. These are without resources. And he said, policy without resources is poetry. It is useless.
So let's talk about
Sorry.
solutions. I think we've spent half the time sort of bewailing the problem. Where will solutions come from?
The solution, I said it so many times in Africa, we have to follow the example of countries like Philippines. They used excise tax to increase the budget of the Ministry of Health 6 times. We don't have to wait for donors. We have so many cost-effective interventions at our disposal. We are telling our governments to excise tax use effectively on tobacco, unhealthy diet, saturated fats, sugary diets, and what have you. I really don't know why they are reluctant.
So let's hear from others as well.
Yeah,
Let's-
thank you.
In
Thank you.
Kenya, what kinds of solutions are you?
Thank you very much. I think one of the best way to approach this is establishing algorithms that can be able to pick some of these conditions within our hospital setup. Typically, for example, in lung cancer, for us to be able to even reach out and screen patients, we must have algorithms that we can be able to use to follow. As it stands today, we don't know which kind of target team we should actually target for evaluating and screening for lung cancer, because we do not have an algorithm that speaks to our situation and our population. Looking at the age, if we look at them, the established algorithm, they're talking about age and I know pack year for smoking, for example. In our setup, it's very challenging to even get a 20-year pack, for patients with lung cancer. So we want to get systems in line, establish policies that are able to then enable us as a team to reach out and identify those patients at the grassroots level and be able to bring them on board for care.
Who will develop these policies?
I believe this is the best platform to do it because one,
this here or back home? Who's going to do it?
Algorithms. I'll give you a typical example in Kenya. For a very long time, we've been able to look at entry areas of lung cancer, for example. We realized that most of our patients are actually within the TB workflow. So we were able to demonstrate this by sharing the data with the government to tell them most patients who are clinically being managed for TB are actually not being treated for TB. They're being treated for something else. We looked at the mortality of clinically diagnosed TB patients vis-a-vis the mortality of the patients who have been diagnosed through the bacteriological diagnosis with GeneXpert. We realized the mortality for clinically diagnosed was very high. So we said then, if it's TB we're treating, how come the mortality is very high? So we picked up this as a team and negotiated for the development of an algorithm that will ensure that patients who visit the TB clinic are evaluated for possible lung cancer. That's where we are starting. Right now, we're actually at the tail end of developing an algorithm that will ensure that patients who are presenting at TB clinic are evaluated further to ensure that if it's not TB, what is it that they are
leveraging pre-existing TB-focused infrastructure to look for other things. Okay.
Yes.
Great.
So this is very similar in our setting where we are also leveraging the TB system. So we are working with a national TB program. It's very widespread. They are well established. They have TB centers across the country. They even have digital X-rays distributed across the country. So where we want to start is, again, we know we've gone past chest X-ray. We are talking about low-dose CT, but we want to, there's some benefit. We want to start there and look at the post-TB cases from the respiratory clinic, look at patients with lung fibrosis, look at patients with ILD. How can we are trying to leverage to get them into some form of screening with this digital X-ray centers. Again, the digital X-ray is already part of the national health insurance system. So you can get patients to do these without necessarily paying more for it. So this is where we are going now, trying to collaborate with the NTP. We are also rolling out educational programs targeting the DOT centers where patients are taken through, like he said, an algorithm so that most of the time they are not smear positive or they are GeneXpect negative. So if you find a GeneXpect negative case, that's in quote, don't just say GeneXpect negative, I'm treating. So we're working to roll out an education program. So we believe there are solutions. It's not all that bad.
So these algorithms will be developed locally.
Yes, yes.
Okay.
Yeah, I agree with the local development. I think there's a lot of potential because, it might sound like everybody was a bit woeful about the situation, but I think there's a lot of promise.
Yeah.
Because one thing I noticed in Nigeria since 2019, there's been a huge expansion in CT scans. So suddenly there's a lot of equipment coming in. We're talking about low-dose CT. There's a lot of equipment coming in. And what are people using that equipment to do? So I've always believed that the private sector should drive the public sector. Nobody's happy with their government anywhere in the world. Everybody hates their government. It's just life that everybody complains and expects the government to do more. But I think the private sector can help in the sense.
So what's attracting these machines into the country?
It's the population.
Mm-hmm.
It's the population. You can't ignore where 20% of the African population, that's 220 million, predicted to be the third most populous country in the world by 2050. You can't ignore that. And there's global migration. There's people going with these conditions to other parts of the world. So we're part of a global village. So you can't really ignore that. So people are coming in. There is also data that showed that a lot of work, healthcare, people travel abroad for healthcare, costing about 25 to 30 billion a year, US dollars. So some people are
medical tourism.
Medical tourism, yes.
So the resources are in the country.
So people are, investors,
take them out
see the opportunity to come in to set up some of these centers. I'm aware in Ghana there's the big Aga Khan Center. There's also, the big centers in Ghana as well. So the equipment is there, but what are we doing with it?
So this is not government. This is private sector bringing
and I believe there is a way to incentivize private sector to contribute to doing this type of work. There's a lot of ways, either through corporate social responsibility or showing them the data about the difference it makes. I think they can be incentivized to do this type of work.
So I'd like to come back to workforce and technology, but I just want to hear about the Egyptian.
For us in Egypt, it's a little bit different because we have almost one city for each patient. Believe it or not, we're poor, but we have cities everywhere. Okay, that's the truth. Okay, because either from the private sector, and the CT is very cheap, by the way. In US dollars, you can do a CT chest for only $9.50. So can you believe it? It's 400 Egyptian pounds. So exactly $10 and you can get CT chest in 2 minutes. And so it's available. But again, how to convince people to go to do CT, first of all. The second thing is, in the government, we have the problem is you have the CT machine, but it's not working. Why it's not working? Because the technical support of the machine costs a lot of US dollars per year. So they drop the contract with the company and that's it. So you have the machine, but you don't have the money or the support to maintain the machine working. You know what I mean? So these are the challenges. We have the machine, we have the patients, and we don't have the logistics. So it has to be somehow organized.
So I think.
So the good news is that our health policy is revised and approved by the Council of Ministers after 30 years of in practice, and it promises to be like to give attention to 40% for NECDs. As I told you, it is a big promise, but it's like it is promoting public-private partnership, and as I said. In Africa, among ourselves, if you go to Egypt, they have something like 100 radiotherapy machines, whereas you have in Ethiopia less than 6 radiotherapy machines. And in South Africa, the story is different. Even in Kenya and Ethiopia, you have. But what I'm saying is, in Africa, our leaders 20 years ago settled in Abuja, Nigeria. And they said they are going to set aside 15% of their budget for health. But no country reached that far. Even in Ethiopia, only 8.5% of our budget is for health, of which 52% is for accounts for NDCDs. We are getting less than 25% of our health.
So what do you propose to do about that?
So what I'm saying is, as I said earlier, we are not advocating for resources for NECDs at the expense of already existing programs. What I'm saying is, let the government increase health budget for up to 15%. They have promised at Abuja, and let them use excise tax as been used in Philippines and Thailand. And the money should be on health promotion, not treatment, not expansion of facilities. Health promotion, Claudia, is the key. In addition to what we do, let's resort and promote healthy lifestyle.
So I will, with all due respect, I don't think anybody here has any influence over how your government chooses to budget and expend. What are the things that we, this community of people here, could do to understand and help you solve the problem?
I think I can just step in to make assistance. Sometimes we always say, can you reach out to the low-hanging fruit? I stand corrected, but I want to say this. Many of the cancer programs within our setup are actually supported by partners. And that's where Claudia was saying, in Kenya, we were meeting the team. We're missing the team component. Now we need to have the team, and the team means all of us. I'm very certain that there could be interested parties here that you can be able to work with to fast track some of the things you want. What happens is most of this government is that when there's an institution that is delivering on particular component that targets their patient, when patients are benefiting, it's very easy for you to sell that idea to the government. The same way we've done with lung cancer. Lung cancer was basically unknown in Kenya for the past 5 years. But right now, when you go in the TB workflow, they will tell you want to look for lung cancer. Why? Because we're able to justify it by sharing the data and looking at what we've been able to do, courtesy of Bristol Myers Squibb Foundation, which is supporting the program that you're running today. So Bekele probably, hopefully, and even Kenya today, we are open for partnership that can demonstrate what we call, the united front in looking at what the government has given a blind eye, because governments sometimes need to be rattled. It needs data. When you show it data and you tell them this is what you can be able to use, even your member of parliament can go there and have something to argue with. Otherwise, if you tell them lung cancer is very, very bad, and they can't count 2 or 3 people in their constituency who died of lung cancer, they'll brush you off. So this partnership that you can be able to develop here, if we can be able to have more partners that can work with us, especially in issues of identifying them early, as my colleague Bekele says, looking at the very, very start point, household level, how do we prevent or how do we identify early, is possible for us to make sure that the government, the exchequer, allocates something for this particular area.
If I may.
Hang on. So we have about 7 minutes left. Yes. So you guys are batting these ideas. We got about 7 minutes. I want to talk. Hang on, wait. We got to talk about the workforce. Okay, yeah. Let's talk about the workforce. Dr. Anosike said in Nigeria, 220 million people, 500 radiologists. You said in Egypt, 1 patient, 1 CT scanner, 1 radiologist. Is that the ratio?
No, we have a lot of radiologists. Actually, we export radiologists out there.
So what is the experience with the workforce? Clearly, there's an amplitude of variation here. What is it? Can you help us understand that in your countries?
Yeah. Okay. Sorry, I don't know if I should go fast. I think that is the main reason why we need to come in and actually partner together and even hopefully have a conceivable way of how we can work together. Because we don't mind if they can be able to give us some expertise as well as them. For us to work together, we can give them experience, for example. But what is most key is that in as much as we have all these quote unquote disparities, we almost have similar things that we go through. They may have 1 CT for every patient, but they may find it a little bit difficult for this patient to access that CT because of probably of other socioeconomic challenges that this patient face, the same patients who are in Kenya and Ethiopia face. So we can see how we can synergize some of these efforts and probably create a consortium that can consult, can advise, and can be able to work together to maximally use the resources that we have. Because as we have a lot of patients, we have very, very few radiologists, we have very few machines. So what is it that you can be able to do?
So how did Egypt get to be replete with a workforce and equipment? And is there something others could learn from you?
Yeah, I believe if we share the resources and we share the knowledge, we can reach our goal. First of all, we have a lot of radiologists. They are well educated, even Western trained and so on. So we can use the technology like teleradiology, for example, to report and help them report their cases according to the LongRads, which we're using now in Egypt. We're using LongRads version 2022, which is the latest. So we can help other countries centralize the reporting. Maybe it could be a solution if they have shortages in radiologists for kind of like collaboration or teamwork. The other way is like you said, is kind of the traveling to a country where they have the resources, and the government should support that, doing the CTs or no CTs according to a scheme where we can use our CT machines, helping others as well, taking imaging. So I believe it can be sorted out.
Yeah,
So,
I think,
exchange of ideas.
Yes.
yeah,
And-
I was
and-
the twofold. The clinical decision trees can be used to help guide people through the the pulmonologists in that environment, on how to manage or triage cases as to who's lung cancer, who's TB, and in terms of picking the population that you want to screen, what the peculiarities in different countries that we could basically work on, see where the synergy is, and try and find out what's common between us, and then at least start from there. But the private sector, like I keep saying, that's where most of the equipment is in Nigeria. Most of the ones in the public sector, most times are broken down and don't always run. But there's a lot of equipment in the private sector. Technology has also bridged the gap, because with teleradiology, you can read from anywhere. I've got in our team, we've got radiologists that are sat in Dubai, Australia, reading stuff in Nigeria. Initially, there was resistance, but later on, they realized that we couldn't take all the jobs because there were no jobs to take, actually. So that it's about trust, also building local trust, people to understand what the gains of this type of program is. Trying to sort of highlight. The politicians don't come to events like this, so they don't know. It's for people like us to go out and educate them and tell them the difference between stage 1 and stage 4 lung cancer and the cost implications and implications to a family. So I think there's a lot of areas where we could collaborate.
So briefly, we have 2-3 minutes left. I want one last question, real lightning round for everyone, but if you'll just be quick with whatever you want to say, please.
So Ethiopia, we have a very good number of doctors graduated every year, more than 3,000 annually from public universities, but most of them are leaving for, abroad, looking for better pay, and some of them are frustrated by the facilities they have. If you go to countries like Rwanda, Tanzania, Botswana, South Africa, Ethiopians are like in a big number. So what I'm saying is, as a lung cancer advocacy forum member, I was so happy to listen to my friend from United Kingdom when they say 70% is stage 1, whereas the opposite is true in Ethiopia. So this can tell you how we are lagging behind, and how we need support from donors like you, to come to Ethiopia and help us to address some of the challenges.
Let's do the lightning round. We're almost done. We're down to 1 minute. I want 30 minutes, 30 seconds, everyone, if you can. 30 seconds, if you can. Tell us, what will it take to maintain a successful lung cancer screening program in your country? 30 seconds. Anybody who wants to start, let's go.
I'd say resources. The scans cost money. It's a low dose technique.
Resources, equipment.
Yeah.
Okay.
Yes, I can go next. Sustaining a lung cancer screening project, you need to have developed policies that can be integrated in existing programs.
Say policies or processes?
Policies, algorithms, a way of how you can reach the patients, and also having a clear way, cascade of what happens when you've already screened the patient. Because remember what Dr. Jeff quote was, there's no patient who should not benefit from an initiative. So if you're going to screen for lung cancer and you find they have TB, they have COPD, where do you take those patients? So having a clearly defined cascade where the patients will go, those with lung cancer or suspicious of lung cancer will face this side, those others will be able to be seen here and there, can be able to sustain.
Okay, good. Let's go to the next person real quick.
So we have a very good...
Were you the next person or have you already spoken? Okay, please go ahead. Go ahead.
In Ethiopia, we have a very good experience. When we started with the Breast Myoscopy Foundation on cervical cancer, the intervention was on 30 or something like health facilities. Today, the government owned it, and we have more than 1,300 cryotherapy machines bought by government, more than 50 LEAP machines. Now, cervical cancer intervention is like at national level. We have already started cervical cancer vaccination at national level 14 years old girls. So the same can be applied for lung cancer.
Great. Ghana?
So what I would say is that, yes, we have a pilot project in our mind. We have developed something. We've thought about what to do. What we would need to get it rolling, well, will be collaboration, which can come in all forms: guidance, support, research is what we lack. So we are also looking to use this to get some data, which is something objective you can work with. Thank you.
In Egypt, we're very lucky, so we don't need except fund. It's all about funds because now the government is suffering a little bit economically. So, so we're ready, but we need the show me the money.
Just need the money. That's
Show
all.
me the money. And that's it.
Well, great.
We're all set.
So thank you, everybody. This has been a very interesting session. I will just say that the IASLC is doing its first sub-Saharan African convention in January in Accra, Ghana.
In Ghana.
Yes. So look forward to that.
Yes.
Thank you very much.
Thank you.